All right, welcome to our peripheral channel. We have Dr. Sam Sayfo from Plano, Texas. He's the director of endovascular fellowship at the Baylor Scott and White, the Heart Hospital in Plano. So, Sam, I think you have some advice for us for below the knee calcification.
Yeah, thank you for having me, and I hope this talk can be comprehensive but not too complicated. And below, yeah, a few slides, a few cases. So let me share my screen. So thank you for Arvin for having me, and I hope we can cover this topic. It's a very complicated topic and very exciting for people who do a lot of below the knee work. The technology is really in the era of evolution. So before we start, can you see my slides?
Yep.
Perfect. So as critical limb ischemia more likely than not has some contribution to below the knee disease. And the reason we care about critical limb ischemia because there's a lot of factors that we're seeing on a daily basis that's becoming more popular. Most of our patients are getting older, so advanced age. A lot of our patients becoming diabetic, even type 1 or type 2, and of course CKD. And the number of patients with critical limb ischemia over across the globe has grown quite a bit. And unfortunately, you talk about almost 4 million people get affected, and for cardiologists, vascular surgeons, interventional cardiologists, the more you ask the patient, you see a lot of those patients with wound and gangrene that is not being recognized. And unfortunately, what that leads to, it's a lot of amputation. So you talk about 80,000 amputation, and that costs $12 billion of direct costs and $23 billion of total costs. It's not something that's small, especially in the era of cost effectiveness. And we say that the higher rate classification that we have, the more amputation and of course more mortality. And we know there is a strong correlation between amputation and mortality in those patients.
It's like a higher mortality than most cancers, too.
Yeah, it's fascinating. I think the Cancer Society has done a phenomenal work in terms of recognize in education and awareness. But patients, even who got, carotid disease, carotid surgery, bypass surgery, they just nobody look at their feet and nobody asks them the question. So, in your practice, how often do you see that?
We see it quite a bit. A lot of our referrals come from, inpatient setting, podiatrists, sending patients into the hospital, and then we get consulted that way on our vascular service.
Yeah, I mean, I think you just spot on. I think having good relation with your podiatrists, I think they're absolutely important. The wound doctors in your area, in your town, in your hospital. I mean, first of all, so many wound doctor and podiatrists doesn't really have the right person to connect with, or they just refer the patient to inpatient. And not every hospital has people who has interest in doing the knee work. Below the knee work is a little bit of a different beasts comparing to above the knee work. And the reason behind it, you see more occlusion than above the knee. It's talking about 60% versus 40%. Those lesions are long, they're tortuous, and definitely they're more calcified. And geographically, now we use a lot of IVUS below the knee. We're seeing more calcified lesions than we thought it is. And then there's exactly those three factors: the occlusion, the long lesion, and the extensive calcification usually led to dissection, bailout stenting, inability to cross the lesion, which lead to failure. And then the recoil is fascinating. You have acute recoil and you have chronic recoil. So this is, we've learned as interventional cardiologists the importance of using IVUS in the coronary, the importance of vessel calcium modification in the coronary, and below the knee act very similar size vessels. You talk about 2.5 to 3.5 vessels. Very
Sam, I'm
challenging.
IVUSing every case now for peripherals.
I love that. So when did you start doing that? Like, is that something recent or that's something
I
just
think
before?
probably started 2, 3 years ago, where I'm like, I'm doing this in the coronary every time. Why am I not doing this in the leg to look for, is it predominantly fibroatheroma? Is it predominantly calcium? Is it mixed? It really tells me exactly what device to use. That way, no one can say, if I have a rep there standing there, I tell them, look, the IVUS will tell me what to do.
Oh, that's absolutely right. And I think for interventional cardiology specifically, we're used to use it for the coronary. And what you see the challenge of IVUS is people who don't use it a lot or who has not been through a true training for IVUS. They can do IVUS, but they don't know what they're looking at. And honestly, if you look at data, we only have two prospective studies. You have, a 100 patient in Australia that was published in Link last year that showed IVUS DCB versus, IVUS versus DCB alone. There's a significant patency rate. And then, of course, the Japanese or colleague in Japan, they just published their called the thing called IVUS DCP study, which showed very similar data. Of course, that's all more SFA and popliteal, but it's
Mhm.
really fascinating. I mean, they've learned very similar lessons that we learned in the coronary. With IVUS, you use larger balloon, you have better patency rate. You can tell if you modified the calcium, so there's no reason not to use it.
I think my colleague too, I remember telling him what size stent I'm putting in an SFA. He's like, "Whoa, you put that size stent in an SFA?" It's like, yeah, the IVUS told me what to do. It's just, you're seeing this in Iliac too, and just stents are way bigger, and same concepts, right? Bigger MSA, higher chance of long-term patency.
Oh, no, definitely. And I think for the iliac, it's always fascinating when I see a patient that someone thought 6.0 stent is even a possibility in the iliac. I mean, to me, iliac should be 7, 8, 9, maybe larger, and especially now with IVL and calcium modification in the iliac. When you do that first and then you do IVUS, you can see some acute lumen gain.
Well,
And
historically they were scared, right? They didn't have anything to modify calcium in the iliac, right? I mean, now with like you mentioned with Shockwave, now more compliance. We feel way better putting these larger balloons in the iliac because they were terrified of a perf.
correct, correct. And if you have a cover stent, you can go with a
Mhm.
cover stent, but you don't want to lose your internal iliac. And
Mhm.
definitely, what you see here on this picture, that's the nightmare that you do not want to have. And I
Mhm.
always tell peripheral operators, till you perforate the iliac, you have not had a complication. Every complication in the peripheral arterial disease is not bad enough till you perforate an iliac. Those are nightmares. So yeah, you're definitely right. IVL has really changed the way we treat iliacs. I mean, we IVL a lot, and there's actually movement now in a lot of operators, especially with the L6, to use IVL as a standalone therapy for iliac. You do
Uh-huh.
IVL, you do 1-to-1 and a 1.1 to 1, and the vessel looks great. There's no dissection. We just have tendency to put a stent in the iliac, and I know some good operators who don't do that anymore.
Sam, let
Uh,
me ask you, how do you treat this complication? Because this is terrifying.
yeah. So, so the first thing you do is, so for us, when we do balloon angioplasty or balloon mounted stent in the iliac, the rule of thumb is you don't take the balloon out of off the wire till you take a picture. And the reason what you do is because when you see that, the first thing you do, you put the balloon back and you inflate it more proximal to the above the perforation. That gives you a balloon tamponading, and then you just take a breath. And then in this situation, clearly we are on the left groin, so you have to go a contralateral axis. You go 8 French or 7 French. You go up and over, and then you prepare your self-expanding cover stent. You deflate the balloon, you put a wire from the top, deploy your cover stent, and this patient did very well.
So do you get contralateral access? Or for
You
this
have
case,
to.
would you get left-sided access?
Right-sided axis.
Right-sided
So
access. Okay.
yeah, definitely you have to. The more challenging ones are the ones that happen in the like the proximal part of the common iliac when you are ipsilateral because
Mhm.
going up and over is very challenging. So this is a conversation for a different day, but I love using radial to peripheral. We have
Mhm.
400 patients in our registry in our hospital. We've published multiple times, and I love doing iliac from the radial.
Mhm.
And people always question is, what about if you have a perforation? Actually, nothing safer than going from radial because when you see the perforation, what you do is you just balloon tamponade it from the radial, and then you have all the time you need to get whatever groin access you need. Plus now, the VBX from Biobond, the lower profile generation,
Mhm.
it's a lower profile, so I can go 7 millimeter balloon expanded that I can expand it to 11.
Mhm.
So we've done that as well on a couple of cases.
And that shaft length is longer too, right? The
They
balloon
have, yes,
expandable.
the 135.
Hmm.
Correct. So yeah, I mean, I think so. The rule of thumb for iliac intervention is try to avoid complication. The second rule is be prepared for complication. So mistakes happen when people start doing iliac cases and they don't have an intervention in the room. They don't have a covered stance in the room. They're not even thinking about it. And when it happens, it's a matter of minutes. The patient will die. I mean, this is mortality is super high if you don't manage it quickly because if you notice, this is just bleeding to the belly. I mean, liters of blood is just coming out.
Hmm. Quickly.
Um, yeah, so let's go back to calcification. Again, iliac perforation is just a nightmare. I hope nobody has to deal with it, but this is how we manage it. But also, if you look at SFA, the data is very clear when you look at the percentage of calcification in a 360. The more calcification you have, the patency rate is lower. And of course, if you do not modify the calcium, and even if you use a DCB, the drug is not penetrating to go to where it's supposed to go. So it's extremely important to kind of modify the calcium in those cases. So let's go to the below the knee. Um, for below the knee, the treatment is very limited nowadays. Before we had let's say 4 years ago, we really had nothing. 4 years ago, we had nothing, or 5 years ago, we had nothing below the knee. We just do balloon angioplasty, lung ballooning, you do coronary stent, off-label use. And of course, if you're in the proximal part, there are some options. Coronary stent has been used, had good data, but then mid to distal really just limited. So that's why the DVA world really picked up because you open those and they close again, or you can't cross them. Calcification, you can't break the calcium. You break the calcium, you have a full dissection. DCB has failed over and over. And for people who does below the knee, most of the time you're doing it either for peripheral ischemia, either resting pain or non-healing ulcers. So it's very important to understand what the angiosome means and treat the ulcer. When you're treating the ulcer, you make sure you treat the vessel that's supplying that ulcer. I see it a lot when people open an AT just because it's easy, and they leave a PT even though the wound is at the bottom of the foot, or vice versa. Patient has a large toe infection. Instead of opening the AT that's occluded and calcified, they open the PT because it's easy. The data is very clear. Really, angiosome treatment is better than just treating the easy one. And this is the thing you just discussed it, just looking at IVUS. And so how do you decide your size of the stent? Do you decide it based on the distal reference, proximal reference? How do you
Yeah,
do that?
for me it's distal reference, and then I can post dilate if I need to. But I usually have the ruler there to kind of help me, and I'll like mark it down, say, oh, I think it's this size at this length. Go up a little bit and find it, and that's also how I kind of choose and decide about either atherectomy or IVL, and choosing it that way.
No, definitely. That's exactly right. And I think, you know, um, the biggest issue with IVUS is if you do IVUS frequently post-intervention, you will definitely see too many dissection. We don't have the data to support what to do with them.
Hmm.
If you see dissection, you put a stent, and I don't think that valid in the peripheral. Um, but we do the same, and we use the IVUS for certain things, recognizing. We had a recent case, very interesting case. We had an in-person training for an atherectomy device, and I took a picture from the case, and I'm like, just didn't look right. And I decided on IVUS, and the patient basically had a thrombus.
Oh.
And when you talk to the patient, her symptom just got worse over the last like week. So she was having
Mm.
symptom, but then all of a sudden just got really bad within a week. So she had a thrombus. You can imagine doing an atherectomy and a thrombus, and this embolization will be a nightmare comparing to thrombectomy, for example. So definitely give you it can save you from a lot of
So
headaches.
often I see this mixed plaque, the
Yeah,
calcium and atheroma on top of it. It's so often. So I mean, historically, when I would do these orbital atherectomy, I'd get so much no reflow, and now looking back on it, I'm not surprised.
yeah, yeah. I mean, definitely a mixed picture. And do you use for your atherectomy? Do you use a filter all the time or most of the
I'm
time?
using IVUS more frequently, so IVUS tells me what to do. If my IVUS shows, it's kind of a mixed type picture or something, I'll maybe reach for shockwave and avoid, orbital atherectomy or something like that.
Yeah,
But if it's really concentric calcification, then you kind of need it. But historically, I've been not traditionally using
yeah.
filter, but
I'm a big
occasionally
fan
I
of
will.
using filter in atherectomy.
Mm,
So if I'm doing excimer laser atherectomy,
mm.
uh, directional atherectomy, orbital atherectomy, um, I'm a fan of putting a filter
Yeah,
just because I've made the mistake of not putting it, and I've had bad disemboliization. And
you're
if
chasing
you
your
look,
tail. Yeah.
yeah, and if you look at the data for some of the studies, that I mean, dissembolization is between 10 to 23%, so they're not
Hmm.
limited, minimal. But I think the IVL, the reason IVL become a really first line therapy for a lot of people, it's easy to use, and I
Hmm.
mean that data is just unbelievable. I mean the data for Path 3 is just unreal. And this implication is zero. I mean, zero. I mean,
Hmm.
that's not just 1%, 2%, it's 0%.
That's been a
And
game changer. Yeah.
definitely. So below the knee, it's really hard to put a filter. So if you look at the way people treated it, still a lot of people do PTA. DCB has failed on every study. Hysterectomy is a little bit harder, but then you don't have a way to put a filter in it. The Ariane laser is very interesting device. We've used it a lot now recently, and their desembolization rate is significantly less than the other devices. But again, for below the knee, there's data from Dr. Shamas about the below the knee laser that is absolutely fascinating. The last paper he published was in AGC, I think it was 6 months follow-up. It's really interesting data. But when you look at DCB below the knee, every trial, man, every trial has failed. I mean, some of them were suspended because how not okay it is to use below the knee. So we can't do DCB below the knee. We're a big fan of DCB above the knee like everybody else, but
Hmm.
below the knee uh, hasn't been successful. And when you talk about atherectomy, I think we covered most of this. Which atherectomies do you have in your lab?
So we have orbital, directional, and ablative. We don't have rotor for the leg.
Okay, yeah.
Mhm.
So we've at one point we tried each one of those. Um, Roto is just too comprehensive. If I'm gonna pull up a Roto, I pull up a CSI.
Mhm.
Jetstream, I tried it for a few cases, didn't have a great result with it. It used to be 7 French. Phoenix definitely did not work in my lab, even though some people really love it.
Mhm.
Rotorex, we have it. I haven't done one yet, but I'm excited to try it. The excimer laser has become very popular for us. We love Hawk and we love CSI like everybody else. They're just good devices. But exactly what you said, it depends on how much calcium you're dealing with, and is it instant versus versus
Mhm.
soft plaque. And this is just a summary of advantages versus disadvantage of atherectomy. So, just the last few slides, just more focus on atherectomy as a technology. I think as a endovascular operator, you definitely should be comfortable with at least two of those because there are certain contraindication for some of them, like instant restenosis. You cannot do orbital atherectomy. You cannot
Mhm.
do directional atherectomy. So it's very important to have laser, for example. Um, but it's just hard to have all of them because all of them is costly. They require space. The hospital never happy when I ask them for another one. It's always like, you just have to kind of compromise to choose one versus the other.
Yeah.
And the data for this, there are actually a lot of atherectomies, but we talk about this, disembolization and dissection really need a learning curve. In our hospital, we actually aside for multiple devices training courses. So, for example, for Hawk One, we trained many times over the last couple of years, and it's required learning. It's just not easy. I think that's what the appeal for therapies like IVL is just the learning curve for IVL is easy. Just it's a balloon. You put it in there, you inflate it.
So
But
Sam,
also
if
the
you had to
cost was
summarize
roughly.
like where you use each. So let's say your IVUS is there, you see it. Where do you use directional versus orbital versus lithotripsy?
So first of all, I look at calcification,
Uh-huh.
and that's my approach. And people have different approaches, of course, and there's data to support each one of them. For me, if I look at calcification, if I see moderate to severe, if I see mild or non-calcification,
Mhm.
I'm very big of either laser or directional.
And are you saying that are you using calcium arc? How are you defining mild?
Oh yeah, this is so even without IVUS. I do it initially without IVUS. If I look
Uh-huh.
at it without IVUS, I don't see any calcium. I can't see the vessel.
Mhm.
Then to me that's mild or
Mhm.
non-existent. If I see just one line, and there's of course the PAC system is available online. I don't think I have it in the slide, but I'm happy to share with the audience later on. But the PAC system is very clear. If you have uh, both sides of the vessel has calcium and you can see it
Mhm.
without contrast, that's considered severe. If you
Got
see
it.
one side, that's considered moderate. That's the easiest way kind of to
Mhm.
look at it. But the way I look at it, if there's no calcium at all, IVL is not indicated, CSI is
Mhm.
not indicated. So if I see if it's diffuse, I like the laser. If I
Mhm.
see it is eccentric and it's just one spot, I like the hawk.
Mhm.
Um, Below the knee, I like the laser more than the hawk. It's just easier to use. If I see moderate severe calcification, if I see a big rock sitting there, a nodule of calcium, I like to spin it before I
Yeah.
shock it.
Mhm.
When I have diffuse kind of calcified vessel, that's where the IVL works phenomenally by itself. What is
Mhm.
your approach? Is it very similar?
Very similar, yeah. And it's funny just because I think it's been so easy to use lithotripsy, even after orbital, I just end up using it on the backside of everything. Just I feel like you just get sometimes maybe I won't focus as much on an area with orbital. Maybe focus on the eccentric. Then I may skip over an area. But with the balloon, especially the E8 balloon being 80 millimeters now, you just treat this huge segment of the vessel, and get nice expansion and fracture, especially after you look at it on IVUS. You see so much fracture everywhere, and then these balloons expand nicely, and it makes me feel good.
Oh, definitely. And the other factor, and I think the next video will be covering that is what I call it, which we learned from the coronary, the non-crossable versus non-dilatable lesions. To me, when I can cross, like if it's 100%, I put a wire and the only thing that's passed is the wire. I mean, that's telling me I need a atherectomy. I mean,
Yeah.
I can deliver the balloon. I think that's also a factor. Um, we 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 were part of the trial for the javelin
Hmm.
from Shockwave, and we are LMR for Javelin. And I have the next talk is completely about Javelin because it's also something that has changed our approach because it's a single emitter that again it's not an atherectomy in any way, but it can help you in those not crossable lesions. So I think that's also will change the way people practice based on if you have Javelin versus you don't have Javelin. So at this point, I want to talk to you about other therapy for below the knee. So we just talked about, PTA, we talked about atherectomy. So, the other therapy is IVL, which I have a few slides about those, but the Serenator balloon from Cajun Medical, and of course the RST from Reflow. Are you familiar with those? Have you used them before?
Serenader, yes, I've not used the RST.
So RST is only trial. There's
Hmm.
two trials for RST. The one that just finished and was presented, I think the 6 months was presented last year link, not this year link. And then now they're enrolling in the drug-coated Beresford stent. It's very fascinating device. It's where you balloon, the stent goes out, and you can retrieve the stent before you finish. So the stent, the spiky part of the stent, tells breaking the calcium, and the scaffold just keep the vessel in this kind of no dissection morphology, and then after a while, just take the stent out. It's very fascinating, and I'm looking forward to use it in commercially. Cajun has been really game changer. I mean, the technology of the serration balloon, I use it a lot in popliteal, below the knee, common femoral, especially now they have the 6 millimeter. Initially I used to not use it because it was quote unquote expensive. But the other day I scanned both the Cernator and the endoscope, and actually the Cernator is cheaper. So I was really blown away because for me it's like I use the endoscope because it's cheap, but it was actually more expensive. So it's a really nice device, and you can use it after you do an atherectomy or you use it after an IVL. It's really a nice device to minimize dissection. And of course, Life BTK, this is the trial that really finally we have something below the knee that's positive, which is the reabsorbable scaffold. And the outcomes 74% in the um, Esprit, which is a device from it's a bioabsorbable scaffold from Abbott versus 44%. A significant difference between the two. And I was in Viva last year, and they presented the 2 years outcome, and it was also positive. So I think we're very excited about it. Have you guys adapted this technology in your hospital?
Not yet, not yet.
Yeah.
Yeah, should we?
Yeah, I mean, I think it's important, instead of putting an off-label drug-eluting stent from the coronary, you can put this one. This is, FDA approved. You have data to
Mhm.
support you and get the bioabsorbed over 3 years, so you're not taking away a future surgery option. Uh, what it's important in this one, and I think we learned it from the same technology that we had in the coronary, is you definitely need to prep the vessel. Definitely need to IVUS, definitely need to size correctly, and you absolutely need to post-dilate.
Mhm.
If you don't follow those 4 steps, you will have stent thrombosis. So people don't post-dilate just because they want to finish with the case. People don't prep the vessel, they just want to put a direct stenting. Without IVUS, you always undersize. So, with IVUS, I'm putting a 3.5, 3.75 stent routinely comparing to the 2.5 or 3.0.
So Sam,
Expensive
where are
though.
you using this then? Is this the longer the better, just to kind of for the dissections, or where do you use this?
Single vessel runoff, I use it all the time if I see any dissection or if I see a recoil. Single vessel runoff, I want to make sure that the patient, because I'm treating this patient for CLI in a wound. Nothing
Hmm.
worse after you finish, everything is great. 2 months, patient start healing, and then 2 months later the wound open up again because
Well,
you have a delay recoil.
hmm.
Um, I do it also in cases where I see bad dissection, like a dissection that's like this is I need to put something in. Is that gonna open? I mean, you have the tack stent above the knee. I've had positive data, personal experience with. Below the knees, I have limited experience, but the data is not matching my own experience. And of course, other than that, I don't think there's any other option for us. But that's my approach.
Yeah, this seems like something especially when you're getting two accesses, like, going retro and integrate, and maybe you do some kind of cart, and you have this dissection plane in one vessel, just, trying to salvage somebody's leg. Finally a stent that can potentially has some good data on it, which is a nice potential therapy. Like you mentioned, this area continues to evolve, and still lack of technology compared to coronary, but hopefully we continue to grow in this to help people out.
Oh yeah, definitely. And of course, people complain. Even fun. It's like for us physicians, even when we get a good device like this, we always complain about why it's not better. So I think the main complaint that I hear from people is, well, it's only 38 millimeter stent, and I need more. So for Abbott, I think working on it, but also we just finished enrolling in Riva Medical that has something called Motive 2, and R3 is starting enrolling. One other company, there's like many companies working on the same kind of, and those I have like significantly longer scaffold, which really reflect the true legion that we see below the knee, like 80 millimeter or longer.
Hmm. Yeah.
All right, so let's talk about lithotripsy. I think we've mentioned it many times, and I think by now, I mean, if you've done peripheral and you haven't done below the knee, oh, if you've done peripheral and you haven't used lithotripsy, there's only two options. Either you just start it, or you work in an outpatient lab where I don't think it's covered. But if you do any work in a hospital and you've been practicing over the last 5 years, you definitely have used IVL one way or the other. It's really changed the way we do TAVR, large bore access, EVAR, TVAR, in the S4 and M5 Plus being the older generation. L6 and E8 are the newer generation. L6 has been really a nice device to have, with large, large size. You're talking about iliacs, where, my last case I did was, you know, infrarenal aortic stenosis, like 99%,
Wow.
in older patient, not a surgical candidate. I went an L6 12. The grading went from 100 to less than 10.
That's amazing.
Angiography, yes,
Yeah.
there is still a lesion. I'm not taking that lesion away, but now I've created a 12 millimeter lumen, and I didn't have to put a stent. It looks
Hmm.
great. So there's really no need to use it to put a stent in those cases. It's just really having able to do 1.1 to 1 to make a difference. And there's the people who like it. And please, I'm just have example, but if you have another advantages of lithotripsy that made you a believer, please share with it. But to me, it's like it's super easy to use. I mean,
Yeah.
it's not rocket science, and the fact that we have data with low complication rate, it just made people leaning towards it. Any reason for you to use it that I
I
maybe I
mean,
did not
like you
cover?
mentioned, I think safe, easy, effective. Simple as that. You look at the atherectomy, they're good, but then like you mentioned, this reflow, no reflow rate of like, more than 10%. It's just so frustrating in these cases. And it's a little bit more cumbersome prep. You need to use a specific wire, things like that. I mean, any standard 014 wire, you can put this down. The prep is relatively simple, and then it's just been very effective and safe, which I love, and that to me is irreplaceable.
Yeah, I think when we adapted, I think we adapted IVL early on when it came out for the peripheral, and the only issue we had is there was no billing for it. But now, the company worked really nicely at getting certain billings for IVL. But the technology is just amazing that, I feel bad that I did not come up with that idea, because you look at this where the emitter comes out, energy you transmit, the balloon wall basically can prevent this scattered energy, but you create this kind of organized energy. So you get the benefit of the energy to break in the calcium and can penetrate through media and intima, but also you're minimizing the risk of this scatter energy that we had when we used to do off-label use for like laser. When I had a lesion where the laser doesn't break, off-label, we just inject contrast and break it, but we always worried about a perforation. So having a safe technology is always helpful.
Sam, when you're sizing these, are you sizing, 1 to 1, one and change? What's your technique here?
Yeah. So I 1 to 1, and actually sometime more. I think the word 1.1 to 1 always confused me. But I would just say just don't undersize.
Yeah.
If I have what it geographically looks like a 5, I put a 5. And
Uh-huh.
geographically looks like a 4, I put a 5.
Yeah.
Below the knee, I use, I would say 3, 3, 5, 4 all the time. I never
Hmm.
use any smaller than that.
It's
Uh,
funny because we only had the 3.5 M5 plus, so I would use that quite a bit below the knee before E8, and I just go up to 2 atmospheres, but the pulse rate was faster, and I just was able to treat the whole vessel going to 2 atmospheres, and I didn't really have like dissections or perforations or anything like that. It's really nice.
Yeah, definitely. And I think the hardest part when someone adapting an IVL is we have tendency to do nominal. And for us, nominal is what, 8, 12 or
Yeah.
higher.
Uh-huh.
And every time I was teaching people early on to use IVL, it's like, please listen, you do not need to go to 8 or 10 or 12. Just
Yeah.
go till you see the dog boning. And when you see the dog boning, you deliver
Hmm.
the energy, let the energy break the calcium. And of course, the M5 has this metal emitter that has a little bit of a higher energy. So that's where I put it for some of this big rocky calcium multinodular, and making it M5 plus instead of M5. I'm telling you, that tells you the company has listened to physician, because
Hmm.
it's faster is better, it's quicker, and people don't have to wait 15-second versus 30-second. S4, we still have it. I think S4 is not going to be here anymore anytime soon. I think very soon, because I think it's going to be replaced by E8. It's just a longer shaft, and you get a 2.5 to 4.0, but 40 length has been really annoying because below the knee is not enough, and of course E8. Knee is 2.5 to 6. You can cover
Hmm.
longer distance. You have more pulses. You get 400 pulses. Um, I mean, I've been a big fan. And this, to me, it's a 150 centimeter shaft. So I do a lot of radial to peripheral. So my common femoral, proximal SFA, and iliac, I use E8. I can do radial. I can do everything I need to do. Of course, mid SFA and distal and things like that. You're gonna have to either not use an E8 from the radial. You can use a laser or CSI, or you have to go femoral access. But 2.5 to 6 basically cover almost everything. The only two
Yeah.
sizes that not covering from the M5 Plus is 7 and 8.
Hmm.
Um, but the difference, and I think this picture show it, is you don't have that um, middle emitter where the pulse comes out stronger. So if you go back to
Yep. Yeah.
M5 Plus, it's more homogeneous kind of energy, which is good and bad. I think if I have a rock, I'm not sure how much this is going to work. So far has been good, but
Hmm.
any
Well, I
thoughts
think
about
that's
it?
what kind of you mentioned before. If you have that eccentric nodule, sometimes you're using both, right?
Hmm.
Some kind of atherectomy on top of this to kind of modify that rock, sand it down, like a dual prep, basically.
Definitely,
Hmm.
definitely. Um, and of course, the newer devices, the E8 and the Javelin. Javelin, we're going to have a full video about it. I tried not to mention Javelin here a lot. Just a fascinating device. I think it deserves um, its own talk. And when you look at the data for PAD3, which is basically SFA and popliteal, and I think we mentioned this patency rate comparing, IVL DCB versus PTA DCB is significantly different at 2 years. And look, randomized trial versus observational. I mean, the complication rate is it's just fascinating. It's mind blowing. The first time someone showed me this data for the PAD3 randomized trial, my first reaction was like, yeah, show me the real life. I'm not believing this. 0.0000 just feels made up. And then literally right away, they published the Disrupt PAD3 observational study. And this is all comers. This is a 1,300 patient, iliac, common femoral, popliteal, infrapopliteal, and the complication rate. And this is all core lab educated kind of legions. So it's not like physician making up stuff. It's fascinating. It's really fascinating. This technology, I think this slide is why people adopted IVL. So, so I'm going to pause here for a second. Um, and I want to ask you, you mentioned this briefly before, and we talked about the sizing. In your mind, and I have four slides for this, and it's not quizzing, but you want to see from your practice now, you're a busy operator. What's your advice for people who just adopting IVL? What's your best practice? What are the best practice for IVL to
I
have the
would say best practices, I would say one, start with imaging, especially new operators. If you're a new fellow coming out into practice, use your IVUS, use your imaging. It'll tell you everything what you need to do. That's one. You get vessel size, you get plaque morphology, and you get, how much calcium there is, and you know exactly where it is. So that's one to see where you can direct your energy. Number two, let's say you do need to use IVL. So just in terms of IVL best practice, I would say definitely one-to-one sizing, like you mentioned. And to be honest, Sam, it's funny because we've run out of so many balloons that so many times I've ended up oversizing my balloon because we didn't have that's the only thing we had on the shelf. That I started noticing, oh my God, we're getting, better results, even just inflating at 2 atmospheres without complications, like you mentioned. So if I'm, it's a 5 millimeter vessel and I have a 6 on the shelf and that's all I have, go to 2 atmospheres, do go back to your IVUS, see where you are, lean on that lesion. And then once you start seeing that dog boning go away, even with 2 atmospheres, you start feeling, oh, that I've really adequately modified this lesion. After that, then I'm using actually a, traditional balloon, right? And I'm ballooning then for 3 minutes. So I do really long balloon inflation. So after my IVL, I'm ballooning for 3 minutes with a, standard balloon. And then on the back side, then I'm usually doing a DCB, for sometimes I'll cut that short maybe a little bit, maybe 2 minutes on that side, but
Yeah,
just to deliver drug.
I love it. I love it. So, I'm going to build on what you just said. So, I think one-to-one 1.1 to 1, or just oversized a little bit because exactly what you said. We are oversizing because, quote unquote, our nominal is 4 atmosphere, and sometimes you don't even get to 4 atmosphere. And people, and again, now people have used this so they understand it, but for the longest time, when you tell people just go 1 or 2, it's like, well, I'm not delivering enough energy because our thought is you have to go to 8, 12 atmosphere, 14 atmosphere, 60 atmosphere to deliver the energy. But this energy, when you emit fire, it's 50 atmosphere. So you're getting a lot of energy through it.
Hmm.
But you gotta touch the wall. If you're
Yeah.
not touching the wall, you're not breaking calcium. The energy will not transmit to the wall. It needs to be touching the wall. So the dark boning to me, it's crucial. And as you said, you look at it as 5, you can use 6. Just don't go to 4 from the get-go. Go to 1 or 2 just to see kind of dark boning deliver the energy, and when it's building up, you just go up a little bit. So that's number one. Number two, sorry, this is just a data to show you that actually the patency rate is better, and
Hmm.
the CDL-TLR is better when you do uh, more or equal 1 to 1, so 1.1 to 1. So this is sometimes people do oversizing a little bit more, and I do that in the below the knee a lot, actually,
Uh-huh.
because below the knee is a little tricky. If I do 10%, that's like zero point 0.1. I don't have a balloon that's 3.1, right?
Yeah.
So sometimes I put a 3.5. And for the cardiologists in the audience, in the coronary, that's exactly what I do. If the vessel is 3.0, I put a 3.5.
Hmm.
Again, this
Yeah.
is from the peripheral to peripheral because I'm seeing those vessels, they're very calcified. They're not a 3.0. They are truly 3.5. You're getting this acute fluid gain that you really want. And because of that, now you're using a bigger stent, which we know, bigger stent in the coronary, it will, better patency, long-term patency. But then in the peripheral, because as you mentioned, it's a very long lesion, you want to make sure that you overlap correctly. And it depends on the M5 plus versus the S4 versus the E8. The overlapping is different because the emitter location is different. And there's just a picture to show you that at least you need to have a 10 millimeter overlap. What end up happening if you don't do that, you can have areas between your therapy spots that you did not break the calcium. When you use your long balloon or DCB, you end up dissecting those locations.
Hmm.
Very important to deliver the energy everywhere.
Yeah, I'm trying to put those emitters right where that dog bone is. That's kind of my goal on fluoro.
Yeah,
Hmm.
100%. And that's a really good point because if you put that emitter right where the dog boning is, you get that nice energy that just hitting it as like a hammer. You're definitely right, and especially in the coronary because you only have 2 emitters.
Hmm.
And then make sure there's no air. I think it's extremely important. I see people initially just pull one, open and go in, and when it just for the first time, I see a lot of bubbles. More bubbles, energy is not going to be transmitted. And
Hmm.
every couple of energy to me is every 2 to 3 cycles, I the air, and I just pull negative on it a couple of times and just keep getting it. The company I think changed something in the console now that will detect too much air and will give you something
Huh.
called error 88. So if you see that, that means you have air in the system. You just have to de-air it, turn it on, turn it off, and it will work. And the last thing we talk about it is, make sure you have the right atmosphere. Don't go crazy on it. And people just go 10 and already you created a baroreceptor dissection. Just go low, dark bone, deliver the energy, and slowly go up. And this is just to summarize it. And then you mentioned something extremely important. Is you know, when you put the 80, sometimes I use it alone and then just do a DCB at the end. But sometimes you have to use another PTA balloon. And if you do that, you just have to go up slowly in a
Hmm.
longer balloon, lower atmosphere, and leave it there. I think that's the art of doing PTA, which we've lost because we're in an era where we're just going to be fast, fast, fast,
Yeah.
very slow. Just take your time, 2 minutes, 3 minutes. It's hard to convince people, but we learn it from the DCB. So
I started doing this and my results have been getting just better and better results every time. I've been so satisfied with the results that that's why I'm sticking to it, even though my cases take longer.
I mean, 2 to 3 minutes, I think it's much shorter than patient has to come back and have a full procedure
Exactly.
again.
Right? Exactly.
So, Okay, so we finished with the best practice. Now I'm going to focus on, I'm going to go quickly on this one. Those are the kind of maybe less exciting slide with just the data. Um, so initially when IVL came out with the Shockwave, the S4, they had something called the BTK trial, a prospective non-randomized feasibility and safety trial. 20 patients in Europe, 30 days follow. Very simple. This is when people did not even know what Shockwave is. And basically looking at the primary safety and primary effectiveness and very traditional safety points to look at it. And of course, making sure the effectiveness is the acute reduction in percentage diameter stenosis. And basically, they were able to deliver 19 um, uh, catheter out of 20. Let's remember this, the S4. And then the measured adverse event over 30 days was zero, a significant reduction in percentage diameter. All patients had less than 50%. So it was a pretty good pilot study. Then, of course, the Disrupt BTK2. This is quite larger study. We were honored to be part of the study. We enrolled the most of those patients. We enrolled 32 patients in the study. We're number one enroller in the study. So I'm very familiar with it, with the PI, the site PI for this one, and basically they're looking at, let's have a larger size pool and look at below the knee and look at the same thing, the safety and effectiveness of the IVL system for below the knee. It's prospective, multi-center, but single arm. Between rather classification 3 to 5, but only 20% can be Rutherford 3. This way they don't skew the result and it's not become, less complicated patient. Moderate severe calcification, up to 2 lesions, less than 200 millimeter in length, which is very traditional for below the knee study. But the only thing is different is you need to look at moderate severe calcification. Most of the devices that now below the knee avoid severe calcification. So this is something very unique. It's a 2 years follow-up, 250 patients, 305 lesions, and of course 38 sites. So if you look at this is real life patients. 15% were in hemodialysis, 70% they're diabetic, 57% had the wound. Of course, gangrene is excluded. That's very traditional. And 85% had a severe calcification. Mean calcification length is 91, and 30% were CTO. Those are complex cases.
Yeah.
And when you look at it, it's fascinating. Like when you look at all this results from Shockwave, it feels like they look very similar, very familiar. Like PAT3, Disrupt BTK2, they all look very similar. So, final 290 patient, 290 legion, final safety profile, 1%. Only 3 patients had complication. It's really fascinating. And actually, the 2 patients with the serious complication, one required undiagnosed minor perforation, was noted on the core lab, and one had acute closure, required DS, drug-eluting stent placement. And the effectiveness, this is very familiar, right? This graph looks very familiar. You have post IVL and final less than 30% residual, 65% required no pre-dilatation, 65 required no post-dilatation, so it was a single device therapy. Of course, you were not allowed to have any atherectomy, so atherectomy was not even an option. If you think patient needs atherectomy, patient is excluded. And I think there was like 2.3% provisional stenting. Just again summarizing it, very impressive result, and there was the acute result, and then they published the 30 days data was published. 30 days data was published at Viva, and very similar result. Again, this is telling you those patients are really sick patients, and finally we have few options to treat those below the knee lesions, and we're looking forward to the 6 months, 1 year, and 2 years outcome. And I think we're going to have some data for this year and some data next year. So what's your thought about the Disrupt BTK2 trial when you heard the result? Would that change your practice?
I mean, I think so. It's just it shows us a real patient population, right?
Mhm.
that it's the ones we see. That's the nice part about it. And then the safety profile, again, that's just what I love about it. The safety profile is so nice that it makes me, it's so easy to use, and that the E8 now with more deliverability, getting all the way down to closer to the ankle too, it just makes it so nice to use. Because so many times, especially in these cases with single vessel runoff, you do IVUS and I see calcium everywhere. I get so scared of distal embolization, no reflow, patients squirming on the table with pain because of all this. You give all the vasodilators you want, and then you're just, you can't use a filter down there either. It's so challenging.
No, I agree with you. I mean, this was the kind of relief to have a technology with this kind of safety profile, and because
Yes.
of the safety profile now, I think that's how the adaptation in coronary become very quick and logical. And now they're working on a trial for carotid and other application. I use it in subclavian, I use it in renals, I use it for iliacs, and it's just fascinating. This technology of IVL is fascinating, and thank God we have few options now. I think the E8 is a game changer, and Javelin, we'll talk more about it in future videos, is